Booth. I'm the Head of Insights and Public Engagement at Bristol, North Somerset and South Gloucestershire CCG. And I joined the CCG just over 2 years ago in November 2018. And at the time, when we then at that point started this journey towards people-centred design. And really the last 12 months or so has really underlined quite how important that journey is, and also the importance of accelerating our work towards there. And for us, we've tried to crystallise down what people-centred design means into kind of really three deceptively simple questions. First of those being, how are we doing? So do we have a real understanding about how users of our system are actually experiencing our services, and what it feels like to them to use it? Secondly, do we actually understand what matters most to people? Have we really worked with people in partnership and applied a co-production approach to really make sure that we're working and designing in services in partnership with people and understanding what matters most to them? And then finally, but certainly a really critical part of that process is then how do we implement change? So how do you can have all the best information in the world from those first two questions, but you can still have a service that change doesn't stick because you haven't really thought about the implementation process in detail. So, the 111 First project really came from in response to the winter pressures that are always there on urgent care services, but also in the context of COVID-19 and reduced capacity in EDs, that we would need to look at directing individuals to 111 First services to really divert them from attending an urgent care service as a first port of call and reduce some of the pressure that would be happening in those spaces, whilst also ensuring that people who really needed access to those services were not dissuaded from doing so when they needed it. So it's important that people knew that the NHS was still there for them in critical moments, but how they use the right service at the right time. So we had really, when we started off in the project, we had two choices. We could have designed it from an operational perspective in terms of what we knew we wanted to implement, or we could really start with a user-centered approach and say, actually, what does it feel like for an individual who's going through those experiences? And what would the stages of the process look and feel like for them, so that we could really sort of follow that journey and really shape the design of the work that we do both now and on an ongoing basis with a real understanding of what it feels like. Well, I think in the past, how we would have done a project of this kind is really to have taken some of the understanding of where people are using it today, and then designed a solution in isolation from users. At best, we may have then spent some time afterwards understanding what the experience looked like and evaluating that, but we wouldn't really have known in detail what was driving points of satisfaction or dissatisfaction through any kind of redesign process. So what was really different for us was actually involving people in that design process. So, these things are still ongoing, and not many of the changes have not been implemented yet. But when they are, we will be able to go back to the feedback we received from people at the design phase and really start to have a bit more understanding about why patient flows will respond in one way or another, because we've kind of gone through and built it up in partnership with people at the very start. So in terms of the project, we were involving both clinical staff and program management staff, but also it's really important for us that again, this mindset of the answer comes from those who are closest to the situation, that actually involving right down to kind of reception staff in the process, so that we could really have those individuals who knew what it felt like on a daily basis and what those interactions would look like, so they could also hear directly from patients going through the process of what it felt like to them. So there could be that good exchange of information on both sides. Well, I think it was really important to involve Mace and Menter in the project because of their ability to really step back from the operational detail and to help us work through not just how do we make sure we design a process where we can work through the design with individual members of the public in a way that will kind of elicit the right response from them, both kind of the rational and emotional responses that we would get from people through the design and understand those and interpret those, but also their expertise in terms of working through the outputs of that engagement work and translating that into, the so what's, which in this case we used a kind of almost a how might we exercise. So how might we design services to improve the experience? And so we went through a series of how might we questions with the clinical team, the program team, and also all of the key staff members, so that they helped us to work through that as a group and helped us to capture feedback and ideas from that the kind of the key stakeholder group as we went through, so that we were able to translate what we'd learned from our engagement work into a set of clear recommendations that could be implemented.
So to be asked to work on the 111 project was a real privilege for us. I'm Sam Menter. I'm the founder and director at Mace Menter. Service design is a really powerful tool for instigating change because it combines research and design. It's about working out how products and services can change based on the specific needs of the users. Combining research and design means we can be confident we're designing the right service in the right way. Solid user research will uncover exactly what people need throughout their engagement with the service at each touch point. And with that understanding, you can improve digital experiences, you can create more effective communication, you can design better waiting rooms, and you can even think about new ways of working. So changes to the way people access urgent care can impact anyone. At Mace Menter, we seek out projects where we feel we can have a significant impact, and this was definitely one of those. Working with Alex and his team was brilliant. They were so engaged and so driven. They wanted the best outcomes for the project, but they also wanted to learn about new ways of working and incorporating service design techniques to their work. Continual learning is one of the founding principles at Mace Menter, and this really added to the potential for impact. So testing a service with users that hasn't yet gone live is always going to be difficult. There's nothing tangible to test. So we needed to find a way of communicating the changes in a way that would be realistic enough for us to get meaningful feedback. The NHS team already had ideas for ways 111 could change, so our role was to interrogate these with real users and help steer the changes in a way that would make them most effective. We created storyboards illustrating potential experiences and scenarios, and we used these as a way of structuring research sessions. We used the insight to explore a series of how might we questions, looking at ways the service could change to meet user needs. So user needs go to the heart of the NHS service standard. It can sound like jargon, but it's actually a very literal term. What do people need from a product or a service to achieve a particular goal? Working in health, it can be helpful to kind of categorise the needs into three main areas. At the top, you've got clinical needs, so what's going to help me get better? Then you've got practical needs, how am I going to access this care? Do I know where I've got to go? Do I know when I'm going to see the right person? And then lastly, you've got emotional needs. Do I feel supported as I'm going through the process? And emotional needs turned out to be quite a strong theme in this piece of research.
I'm Natalie Vanns and I'm a service designer at Mace Menter. I think for me, particularly with the last year that we've had, being able to work on the 111 First project, it was just a really important project for me to take part in personally. health has always been a really interesting space that I'm naturally drawn to working in. So to get the opportunity to contribute and use my skills to help such an important service was really important to me personally. And from a professional perspective, I think the way that we worked in 111, we, in the space of 2 weeks, produced a great deal of insight in a really efficient way, working really closely with people in the NHS team. So that way of working for me was just a really great example of how quite quickly and at pace you can produce some really great insight to improve the service as well. So the first thing that we did on the project was to look at the clinical pathways and proposal for that, and that's very much in a sort of flow diagram sense. So we consumed that, and we had interviews with people from core services. So we had discussions with people from the minor injury units, and it was a range of nurses, clinical staff, receptionists, so a breadth of people who would be affected at those sites. And we understood the process from their perspective as how they would see this new process working. So we spoke to people from minor injury units, people from urgent care, and also people from NHS 111. And after we'd done that, we then basically pulled together everything that we'd learned and distilled that into a more visual storyboard. So basically taking the flow diagrams, but bringing them to life with actual scenarios. So we had a couple of scenarios. We did 4. 2 that would go to the minor injury unit and 2 that would go to an urgent care department. And for each one, we had slightly different scenarios. So we had one which was much more of a physical, obvious injury, like I think we had a sprained wrist. And then we also had something like, an abdominal pain. The reactions to those different things that a user might have are very different. So it was very intentional about, testing different types of scenarios, which might have different emotional responses as well, and different pain levels potentially as well. So once we'd done a range of those storyboards, we then basically did walkthroughs with participants who had recently gone through urgent care. We started off those discussions by asking them to talk us through that recent experience. And the reason that we did that is to really bring that experience to the forefront of people's minds. We can't talk to people, whilst they're actually going through an actual scenario where they need to access care. It's important that people, access the care that they need in that scenario. So therefore, we talk to them about what they'd recently gone through to understand and put that at the forefront of their mind. And then once we'd gone through that and understood their recent experiences, we then talked them through step by step a scenario, so the visual storyboard, but then also we had it narrated with a script and described, you've just had this accident and this is happening, and what would you do next? And also, how are you feeling at this point? And we did that by showing a range of emojis on screen and just asking, how are you feeling right now? Which accompanies the action of what they're actually doing, which is quite insightful actually, because sometimes like the practical side of what you would do, that's only one side of it. You get a lot more sometimes through or coupling it with how are you feeling right now as well. And then once we'd done that, that was the main insights. We analysed that and distilled that down and mapped out all of those reactions and quotes onto the journeys to understand where the pain points were, where the dropouts were, what the causes of those dropouts might be. And there were some interesting insights around time, for example, and the language that's used. So that was an interesting one, because when we went through the storyboards, we were very intentional to to stay to the script of what was going to be said, which was, you're given a time to arrive. But people were inferring a lot of different things just from that language of, they were instantly sort of saying themselves, I'm going to get an appointment, I'm going to get a slot, which isn't what has been said, but it's useful to know that that's where people could potentially be going in their mind. And what do we want to do about that, in terms of adapting and communicating in the service when it actually goes out live. So one of the interesting insights, it was a bit unexpected when we got to the end of the interviews that we did during the analysis and synthesis, we could basically identify the behaviours that people had or the scenarios that they might have. And they kind of loosely fell into 4 kind of categories of behaviours and needs. So the first and the largest group was people who were trusting and cooperative. So they would generally stick to the task and would follow the advice that had been given as to what to do next. And they might say things like, they're the professionals, I trust that they, will give me the best advice. The next type of group was people who are really confident in their own judgment. And they might be people who are either just particularly confident in their own opinion and judgment and don't feel like they need a second opinion, maybe wouldn't naturally seek one. They might have medical training, so they might have done some first aid training, or they might have prior or additional knowledge than most people would about a particular condition like a burn, for example, and they might already have knowledge like, I know that this needs to be treated quickly. With that knowledge, they feel like they know enough already to make that decision, and even if they know that they or might have heard that they need to contact 111 first, they're still going to go. They're still going to look at this and go, I know that needs to be seen quickly. I know that maybe 111 first is the advised route, but I'm just going to take the initiative and go where I think personally I need to go, and I'm going to go now so I don't lose time. So it's useful to know that even with this route, that type of group exists, so that we can prepare and adapt for that. And then the smaller types of groups that we encountered were people with chronic ongoing medical conditions that would particularly maybe affect their everyday. So they might be people who are in pain every day. They might be coping with symptoms which on a daily basis they might flare up, for example. But they are symptoms which require a different kind of handling, and they might flag up on the 111 triaging system as red flags. And in a couple of cases, we spoke to people where they had been taken to A&E, but it's actually their everyday normal. And then there's a whole, waiting scenario with that. So with that insight, in that type of person, it's highlighting, actually, is that the best route? Is there a way that we can highlight people as they come through the system? Or how do we handle, people with those chronic ongoing conditions in this context? What path is the best path for them? And then the last group was people with higher anxiety, and particularly in COVID, that anxiety might be understandably higher, particularly when the thought of, I might have to go to an A&E or department or any scenario which is outside of my own home, with other people, and in the context of, I have this medical urgent care scenario or injury that I'm really worried about, that escalates it even further. So that user group might be more likely to escalate to 999 or drop out.
Well, I think the really important thing about all working together through this was that everyone had the same understanding and everyone had the same set of information to work from. So it actually gave everyone the same grounding in terms of experiences of patients. And it's worth remembering that whilst clinical staff will have contact with individuals on a daily basis, they won't always hear all of the conversation. So they won't always hear what the patient says afterwards, after they've left the room. They'll only see and hear what that patient shows them at the time. And so it's really important for them to understand what an individual might say, maybe, or the way in which they behave will be guided by how they're feeling at that moment in time. And that was one of the really critical things that came out from the Mace Menter approach, was the use of emoticons during the engagement with individuals to really sort of gauge what the emotion felt like, because that ended up being a really important insight from this. It's as important what people, as important as what people do and say is how they're feeling at that moment in time, because that really underpins everything. So that was one of the key things that came through from that. I mean, I think one of the most obvious challenges for doing a piece of work like this is that most of the team involved, particularly clinicians involved, it's very difficult to get time in diaries with everyone to engage with work like this. In lots of ways, working virtually enabled us to get more time than we otherwise would have done with some of the key individuals as part of the programme. But even with that, it's always a real challenge to work around their frontline requirements, which always have to come first. But one of the things that we did in that is that working and creating kind of digital spaces which summarised all the things that we'd learned and giving everyone kind of open access to those so they could edit and add things as they occurred to them was really important in terms of summarising where we were on the journey and really taking people with us all the way through. The other challenge is obviously then around whilst there may be ideas and concepts that come out from, the way in which users would like the way the service to work, there are obviously significant technical and operational challenges to being able to implement those changes. But that's why we really kind of have used this piece of work as a kind of something we'll keep coming back to again and again as the service continues to develop and evolve. And then finally, in the context of COVID, it's obviously been extremely challenging to then evaluate the outcomes of the changes that have been implemented, because it's making sure that we're gathering feedback in a safe way that doesn't impact on what is an incredibly pressured situation. But we're currently working with our partners within the hospital trust to gather feedback from service users at this point, and we look forward to seeing what the learnings from that are and how that can allow us to continuously improve the services. So I think one of the critical outputs from this piece of work was that it actually played a role of being a pilot for a way of, bringing this people-centered design approach to a much more wider and more commonplace approach across the whole of the system. And that helped us to become one of the key case studies for establishing a user experience lab within the Southwest, where we can really formalise our approach to doing this work on an ongoing basis, share learnings that have come out from projects, and also work in partnership with colleagues in systems across the region. For me, it was this was a really incredibly successful project in terms of allowing us to shape what's possible and to open people's eyes to a different way of working and really demonstrate what's possible when we take a different approach and when we start by thinking, what would happen? How do we do this differently if we put the user at the heart of it? And actually, it then gives us the confidence that actually, if we can have a conversation starting in that way across the system, and if everyone was to start any kind of change or quality improvement process with that same question of how would this be different if we put people at the heart of it, it would make a transformational approach for our system as a whole. So it really gives us that inspiration of what can be possible by working in a different way. Well, I think working with Mace Menter is one of the things that first attracted us to working with Mace Menter in the initial discussions around the programme was quite how flexible they were willing to be around the timescales, the resources, the budget we had available. And actually getting something that would bring in something that was credible and gave us best practice, but actually allowed us to learn as an organisation. And Mace Menter are incredibly generous with their time and incredibly generous with their tools and approaches in terms of sharing them. There isn't a black box that they use to say, well, this is how we do things. We're not going to share that with you. It's always a spirit of partnership with us to help us improve our understanding. But also they bring a wealth of understanding for a range of sectors in terms of how this work needs to be done and how we can achieve the best goals that we can.
I thought it was a really great project, and I think one of the things that stood out in my mind was just how efficient the use of time was and how much you can achieve. Particularly, I think one of the key things was the one team thing, and having a really close-knit team that touch base frequently, and you can really run at pace and get a lot of insight in a very short space of time when you really sort of efficiently strip it down.
If you work in an organisation that's thinking about how to be more people-centred, one thing I hope you'll take away from this case study is that you don't have to start with a big bang. This project was essentially a pilot project for Healthier Together, but it's had a big impact. You don't necessarily have to recruit new people and make major changes to start working in this way. If there are people in your organisation who are already interested in people-centred design, setting them up with the right support, tools and permission can have a big effect. Experiment with a few projects. Let them work alongside more experienced service designers and researchers to start building up skills, and hopefully it will snowball from there.